Again. It's a pleasure to welcome Professor Adelstein Brown, the Dean of the Dalai Lama School of Public Health. And we're very grateful for the Dalai Lama School of Public Health assisting us with putting on this event today, for hosting the 2024 Friesen Prize program to honor Professor Gordon Guyatt. The Friesen Prize and the related events today are organized by the Friends of CIHR, which is a national organization focused on the support of health, science, and society. It was founded by Professor Emeritus Abby Angel back in the year 2000. Next year is our 25th anniversary. FCIHR advocates on behalf of young people as career scientists and encourages the funding of health research in Canada. We are very supportive of the goals and ideals of CIHR and other health funding agencies and are eager to recruit young people to our activities across the country. This year, we are honoring Dr. Gordon Guyatt, the 18th Henry Friesen International Prize winner, who was selected for his pivotal role in developing the concept of evidence-based medicine and advancing its application to medical education, research methodology, and clinical decision-making, which you'll hear about. In addition to the events today in Toronto, Dr. Guyatt will be visiting the University of Ottawa next week, then Waterloo University in February, University of Calgary in Alberta in March, and McMaster in May. And we're still working on the UBC dates, which are probably in June. As I said, today we celebrate the 2024 Friesen Prize awardee, the 18th since its founding. And we're very grateful to Dr. Gordon Guyatt for accepting the obligations associated with the 2024 Friesen Prize. A brief biography of Dr. Guyatt is provided in the announcement you have in the program, so I'm not going to take much more time away from his lecture, but I will highlight that through his long career, Dr. Guyatt has had a profound influence on the development and implementation of the concept of evidence-based medicine. He is an inspiring and visionary scientist, clinician, teacher, and communicator. So thank you, Dr. Guyatt, for accepting the 2024 Friesen Prize. We look forward to your lecture entitled The Foundations of Evidence-Based Medicine. And as you know, there will be subsequently a roundtable on the title Future of Evidence-Based Medicine, chaired by Professor Ross Upshur, and chaired and panelists Professor Allan Detsky, Lauren Lapointe-Shaw, and Professor Naylor. So, Dr. Guyatt.
Thanks very much. I have the portable mic. Everybody hear me all right? Yes? Okay, great. Okay, I don't know why that awkward thing is on the screen. There we go. Evidence-based medicine, past, present, and future. I'm going to start by describing what I think EBM is all about, three key principles. I'm going to take a historical approach in which I will introduce you to the people who have made evidence-based medicine. I'm going to talk about its evolution and then talk about what I think are the successes of evidence-based medicine highlighted in the epidemic. So this is the first paper that evidence-based medicine, the term appeared in the medical literature in 1991. And to give you an idea of how long ago that is, that's what I looked like at the time the study was published. Dave Sackett was my mentor. He was the mentor of a number of people who ended up taking leadership roles in evidence-based medicine, and he made many pivotal contributions, including the first go at a hierarchy of evidence. And this hierarchy of evidence acknowledged that clinical experience is a legitimate form of evidence, as is basic research and observational studies. But they all have limitations, and so at the top of the hierarchy for therapeutic issues was randomized trials. This was a very simple hierarchy that served us well for a while. I will talk later in the presentation about the much more sophisticated hierarchy that has replaced this. This is Ian Chalmers. He is the guy behind the Cochrane collaboration. His, as I describe in the next couple of slides, his contribution has also been pivotal. The four evidence-based medicine, how were decisions made? This slide, I think, provides a good depiction and shows why evidence-based medicine was necessary. This is a forest plot that describes thrombolytic therapy and the potential benefits of thrombolytic therapy in patients who've undergone myocardial infarction. The 1.0 horizontal line down the middle is no difference in death rates between those who did and did not receive thrombolytic therapy. 0.5 presents a 50% odds reduction. 2.0 would be a doublet. The dots represent, as you go down, represent the point estimates of the data as it accumulates. The numbers on the side, the first randomized trial of thrombolytic therapy enrolled 23 patients, and as a result had a very wide confidence interval represented by the horizontal line associated with the dots. The second randomized trial enrolled not 65 patients, but 42. This is a cumulative meta-analysis. By 7 trials in under 2,000 patients, the confidence interval still crosses no effect, and thrombolytic therapy may be beneficial or harmful. By 10 trials with 2,500 patients, the confidence interval doesn't cross, and by 30 trials and over 6,000 patients, we now have a very narrow confidence interval with a very low associated p-value. One might have reasonably inferred that the answer was in at that time with a 25% odds reduction in death. And one might have reasonably said it's time to stop doing randomized trials. Did they? No, they did not. They enrolled another 40,000 patients after the answer was in, half of whom did not receive the life-prolonging benefits of thrombolytic therapy. Why? I think the reason why is primarily on the right side of the slide, which is expert recommendations appearing in textbooks and current review articles as these data were accumulated. And you can see two things. If you look at the middle of the 1980s, in the recommendations, which could be routine, give it everybody. Specific indications, experimental or not mentioning, it's all over the map. Some are beginning to get the methods, but some are still calling it only for specific indications. Some referring to it experimental, and some not even mentioning thrombolytic therapy. And it is a decade after the answer is in that finally the experts get it, and that's why the trialists had to keep doing trials. Here is a second example, also for patients with myocardial infarction. Okay, thank you. Oh, are people hearing me? Yes. Okay, thank you. Okay, that's good. I like that better. Okay, so 45 years ago, I was in training in Toronto in internal medicine, and when I rotated through the cardiac unit, every patient who came in with a myocardial infarction, I started what we called a lidocaine drip, an intravenous infusion of lidocaine. Why? Because we knew patients after myocardial infarction were at risk of lethal arrhythmias, and lidocaine biologically was a lovely antiarrhythmic. It made a lot of sense. Was there ever any evidence to support my practice? No, there was not. Here, if you look at the point estimates, they are always on the harm side. Increased mortality with lidocaine. We never showed definitively showed increased mortality, but we certainly excluded any benefit. So I was giving this lidocaine to my patients, putting them at risk of all the harms without any benefit. Did this stop the experts from recommending lidocaine. If you look at the right side of the recommendations, once again you see the extreme variability in expert recommendations, most recommending in favor, and that's why I was doing it. Okay, these are old stories. They end around 1990. Experts still make mistakes. They still disagree with one another, but perhaps I don't think quite as badly as these stories suggest. Something happened in 1990 to change the picture. Anybody want to suggest something happened in 1990 to prevent this sort of egregious mistakes and disagreements? Anybody got to guess what it was? The internet. No. That wouldn't do it. And the reason it wouldn't do it is, as we all know, there's a lot of junk on the internet, and we have to differentiate what's junk, so internet by itself would not do it. What would do it? What would do it is systematic reviews and meta-analyses. Systematic reviews and meta-analyses were not around before 1990, and they only started to gain traction just about that time. And I would suggest that if the experts who were a decade behind the evidence with thrombolytic therapy and making recommendations that contradicted the evidence had seen the systematic reviews and network and meta-analyses that we've seen here, they would not have made such mistakes. They would have come to agreement early. They would have not been recommending a useless and harmful therapy. So, next individual I'd like to introduce you to is Brian Haynes. Brian Haynes has made many contributions to evidence-based medicine. I'm going to focus on only one, which was a paper that appeared in 2002, where he said physicians and patients' choices in evidence-based medicine, and he made the statement, evidence does not make decisions, people do. So I'm going to illustrate that with a study done by P.J. Devery, who is now leading the world in perioperative medicine. But before he assumed that role, he did a study that I'm going to tell you about. And I'm going to want to now enroll you in this study, and you will act as participants in a little while. So he presented patients with atrial fibrillation who, without treatment, 12 in 100, 12%, will suffer a stroke, and some will have serious GI bleeds. Anticoagulation would decrease strokes in 100 patients to 4, 8 fewer strokes, 4 major and 4 minor. And Dr. Devery asked his study participants, how many bleeds would you accept for that reduction in 8 strokes and still use anticoagulants? In asking that question, which is one that you are going to, I hope, try and answer in a minute, he had to tell his patients who were participating in the study what it is to have a stroke. Minor stroke, you suddenly cannot move or feel one arm and leg, have difficulty expressing yourself, but over the next little while, you will basically recover, but you do have weakness, numbness, and understanding improvement, but still feel weak and numb in one arm and leg. That's a minor stroke. Major stroke, much worse. Unable to move arm and leg, can't swallow or control bowel and bladder, unable to understand or talk, no physical pain, admitted to hospital, cannot dress, walk, nurse feeds you. You get better, but are still have major disability for the rest of your life. That's a major stroke. And he also told people, his patients, what it was to have a major GI bleed. Admitted to hospital, doctor puts a tube down your throat, receive sedation, don't need an operation, receive blood transfusions, stay in hospital a week, and then gradually recover from your GI bleed. So, now that we know what it's like to have a stroke or a GI bleed, I would like you to answer the question. If you were in a situation where 100 patients 12 will have a stroke over the period of the follow-up we're talking about, anticoagulation would decrease strokes. 8 fewer, 4 major strokes prevented, 4 minor strokes prevented. And the question is, how many bleeds would you accept in 100 patients and still be willing to administer as a clinician or take as a patient anticoagulants? Any questions about, I'm going to ask you what your answer to that question is. Any questions about the question before we do? Okay? All right. How many would say I'll accept 5 or fewer bleeds. If it's more than 5, no anticoagulants. How many say 5 or fewer? Anybody? Okay. How many would say up to 10? I'll accept up to 10 bleeds, but not more than 10. Okay. Now we have some people. Who would accept up to 15? If you voted, don't vote again. Who would accept up to 15 bleeds? Okay. Lots of people up to 15 bleeds. Anybody accept 20 or more? Okay, all right. Okay, this is a very enlightened audience. Okay, here is what happened when Dr. Devereux asked his patients and his clinicians. Look at the clinicians. Flat distribution, they're all over the map. Some less, quite a few less than 5, and then right across. When I have asked this question to general medical audiences, you folks did a lot better if approximating patient answers is seen as better. I have replicated Dr. Devereux's findings over and over with general medical audiences. Look at the patients. So the patients, 2/3 of them are 20, they'll accept 22 bleeds. Why 22? Seems like an odd number. When Dr. Devereux did his study, he was thinking like a clinician. He didn't think they would accept more than 22. Had he given them the chance, they would have. Okay? So what's the message of this? The message of this is that the patients are much more stroke averse than the clinicians. The clinicians are much more bleeding averse than the patients. That's one key message. The second message is that there are some patients at the other end who are bleeding averse the way the physicians are. So 2 messages. Number 1, if we accept the clinician values, we got a problem. We've got the patients are the ones who are bearing the consequences of the decisions, and it should be their values and preferences. But the second message is that taking average patient values and preferences gets us much better than the physicians, but that still doesn't do the trick because of the variability in patient values and preferences, as demonstrated here. Most very stroke averse, and some bleeding averse. Okay, so I've reviewed what I think are the 3 key principles of evidence-based medicine. 1, some evidence is more trustworthy than others, and evidence-based medicine provides a hierarchy to differentiate the more and less trustworthy evidence. Second, the best clinical care requires systematic summaries. We have seen how very smart experts go very wrong without systematic summaries of the evidence. And the third principle, perhaps a somewhat ironic principle of evidence-based medicine, evidence by itself never tells us what to do. It's always evidence in the context of patient values and preferences. Next individual I'd like to introduce you to is Andy Oxman. Andy Oxman worked with us at McMaster for over a decade, then moved to Norway where he now resides. And sad for me, a lot of my people who I trained, as I did with Andy, are now retiring. Okay? Not Sandy, they just recently retired. But long before he retired, he came up with a great idea, which was that focused on systematic reviews and guidelines, that we need to have a hierarchy of evidence. We need to say what evidence is more or less trustworthy, and we need a process of going from evidence to recommendations to have trustworthy guidelines. And we called the system that he developed GRADE. First published in the BMJ in 2004, subsequently a 6-part series for clinicians, understanding GRADE, and from 2011 to the present, in the Methods Journal, the Journal of Clinical Epidemiology, over 40 articles describing how to use GRADE, and still going. We've been very happy with the uptake. Over 110 organizations worldwide are using GRADE. They are very prestigious. Some of them World Health Organization, leading American organizations, American Thoracic Society, American College of Physicians, Cochrane collaboration, very important, using GRADE. and perhaps the most important, in my opinion, up to date, which is the leading electronic textbook all over the world, the #1 resource that physicians go to, has over 10,000 graded recommendations. So here's how grades suggest we have decide what evidence is more trustworthy and what is less. Remember I told you about Dave Sackett's very simple hierarchy of evidence. This is the new, much more sophisticated hierarchy of evidence. On the right side, you can see the evidence will be high, moderate, low, or very low in quality or certainty. Randomized trials, going over to the left, start as high certainty evidence, but there are 5 key categories of problems that may make randomized trials end up as something considerably less than high quality or certainty of evidence. Risk of bias, lack of concealment, lack of blinding, lots of patients lost to follow-up, imprecision, not many patients, not many events with wide confidence intervals, indirectness. I work as a hospital-based secondary care internist, and nowadays probably a large portion of the patients I see are over 80, and now quite a few over 90. I try to base my practice on the results of randomized trials, but very few people over 80 and very, very few over 90 participated in those randomized trials. I am less confident applying the results of those trials to my older patients, my very old patients in particular, than to younger patients. In other words, the results from the randomized trials in younger patients provide, in the grade way of looking at things, indirect evidence for the older patients, and we lose our confidence or certainty as a result of that. Inconsistency in the results. Some trials suggest benefits, some don't, and you don't know why. And finally, the suppression, typically, of results that do not favor treatments in publication bias. So randomized trials start with high certainty evidence, but lots of reasons they then end up with moderate, low, or rarely very low certainty evidence. Observational non-randomized trials start as low certainty evidence in this hierarchy, and they can go to very low because those 5 problems can inflict observational studies as well. But on occasion, observational studies can yield high certainty evidence. What kind of situations are we talking about? We're talking about resuscitation after cardiac arrest, where everybody used to die and now some don't. We talk about hip replacements. We talk about insulin and diabetic ketoacidosis. We talk about epinephrine in anaphylactic shock. And there are a number of them, not an awful lot, but there are a number of them which share the common denominator of very large treatment effects and in some occasions a dose response gradient. So there is the new hierarchy of evidence, a much more sophisticated hierarchy that we think is serving us very well. This is how the grade approach summarizes the evidence when you have done your systematic review and the evidence is in. It's something called a summary of findings table. This is for patients with severe or critical COVID, and it compared baricitinib to standard of care. On the first column, you see the different outcomes. What does baricitinib do to mortality, mechanical ventilation, adverse effect, hospital length of stay? I'll go across on the first row. Now, I'll ask a question before I go across. What do you think is more important to patients, relative effects or absolute effects? Who thinks relative effects are more important? Okay, several people. Who thinks absolute effects are more important? Most. Who's not sure? Okay, a couple of people not sure. Okay, let's say a treatment has a 50% relative risk reduction. Most people would agree cutting bad events in half, that's nice. That's a big effect. We should clearly use this treatment. But what if it has side effects? Makes your hair fall out, makes you feel nauseated, makes you fatigue. Not so good. Should we use the treatment? 50% relative risk reduction in mortality. Mortality is important. Still sounds great. But what if your baseline risk of dying is only 2%? So your 50% relative risk reduction goes from 2% to 1% with all these side effects. Maybe not such a good idea. What if your baseline risk is 40%? that 50% relative risk reduction goes from 40% to 20%. That's 20% mortality reduction. Maybe now you're ready to put up with adverse effects. So that 50% relative risk reduction really didn't tell us very much unless you know the baseline risk and then the absolute. So the absolute is what's important. Okay, so here you start out with the relative, but we've just decided you better tell clinicians and patients about the absolute. So you have the event rate in the comparator standard care, in the intervention, and you see how many events are reduced. In this case, 45 fewer, 4.5%, and you see the confidence interval. You have the certainty of evidence by that system that I just told you about, the great certainty of evidence, and then finally a plain language summary. In this case, baricitinib probably reduces mortality. So that's the grade. The grade summarizes the evidence. Now, grade also suggests a way of going from evidence to recommendation. So strong recommendations. Good things outweigh the bad things, or bad things clearly outweigh the good things. So that's strong recommendations. But what can move you from a strong recommendation?
Or get that thing out of your pocket.
Thank you very much.
Like a hurricane.
Oh, is that right? That was excellent advice there.
I didn't hear it, Lauren.
You didn't hear it. Well,
I heard it.
getting over there. Here you go.
Thank you.
Okay. All right. Thank you for that excellent advice.
It only happened when you got animated.
Okay. Well, I still want to stay animated, so it's a very good suggestion. Okay. So what can move you from a strong recommendation to a weak or conditional recommendation? So if you're not sure of what the benefits and the harms are, how can you make a strong recommendation? Strong recommendation, you're supposed to be confident of the benefits and harms. But if you aren't confident about the benefits and harms, how can you be confident in the difference? Or a close balance between the two. And we've seen when there's a close balance between benefits and harms, because of differences in values and preferences, people are not going to make different choices. So a strong recommendation becomes inappropriate for that reason. Okay, we like this strong and weaker conditional recommendations. Why do we like it? We like it because it has important implications. Excuse me. So, one way of thinking about a strong recommendation that we like is if you have fully informed patients, you told them about the upsides and the downsides, everybody or almost everybody would make the same choice. That's a strong recommendation. A weaker conditional recommendation, because of differences in values and preferences, patients would make different choices. That has implications for interaction with patients. When I go around the world talking to medical audiences, there is one question I ask where I always get the same answer, no matter where I am in the world, and it's always 100%. And that question is, do you have enough time to spend with your patients to do the job that you would like to do? And everybody says no. Okay? So that means we are time constrained, and we have to ration our time with patients. Grade and strong and conditional recommendations can help you do that. A strong recommendation, if a guideline panel's got it right, if you did a full shared decision-making exercise, everybody, almost everybody, would make the same choice. Not a great use of our constrained time. On the other hand, a weak or conditional recommendation tells the clinician that patients, because of different values and preferences, if they were fully involved, would make different choices, and then you need shared decision-making. And finally, use of a decision aid. Strong recommendation, if the panel's got it right, probably not necessary. Weak or conditional recommendations. Shared decision-making is tough, and decision aids can help. All right, so how to ensure we decide that third principle of evidence-based medicine. Evidence never tells us what to do. Evidence in the context of values and preferences. In guidelines, we have to use average values and preferences. But we've seen in that anticoagulation example, most of the patients were very stroke averse, but some were bleeding averse. Get it right, you have to go to the individual patient. Victor Montori trained with us for a couple of years, has gone back where he's a professor at Mayo Clinic, and he leads the world, in my opinion, in shared decision making. He's an endocrinologist, deals with a lot of patients with diabetes, and has come up with this great innovation in shared decision making. He says, okay, we've now got lots of drugs for people with diabetes, and the patients choose between them. So he has these cards, and they say, they describe the merits and demerits of the treatments with respect to weight change, hypoglycemia, control of your blood sugar, daily routine, sugar testing, cost. And he says to the patient, which one of these would you like to know about first? What do you think the patients choose most often? Cost is one, and the other suggested, weight. And the answer is weight. 40% of the patients, Victor tells me, would choose weight as their first. And then they might say daily routine. And then they might say cost. And then they might eventually look at all of them, but they never do. Never. Okay. They typically look at 4 at the most of the time 3, even 2. And after 2, they've made their decision. Efficient, shared decision making targeted to what the individual patient wants. And if all goes well, I will now show you Victor doing shared decision making. Ah, what a sad thing. We had the sound working when we tested. There.
So, which aspect of your next study's medication do you want to discuss first? Weight change. Let you review that.
So this is the one that,
Yeah, you're already on metformin.
this one was good to me.
Yeah, that one is going to help you lose some weight.
Yeah.
What aspect of that medication would you like to learn? Next.
I'd say the daily routine.
Sure.
Also, this is an injectable.
Yeah, it's actually very easy. There are a couple of pens that have needles, and you inject a needle into your belly and do that twice a day before your meals.
Yeah, I don't think I really want.
You don't want to go needles?
No, I'd much rather just pills.
Mm-hmm.
So this is okay. Well, so this sulfonylurea is.
That's the next best one for you. There's the weight. Huh?
Yeah.
Well, that's the daily pill, so that you can start with just 1 pill a day.
Yeah, and just 30 minutes beforehand.
Yeah, usually 30 minutes before breakfast. Would that be okay?
Yeah.
Okay, well, the other thing to consider is that sometimes they can give you low blood sugar, so we're going to ask you to monitor a little more often than you're doing right now, but otherwise that would be okay. If you were to change your mind after you go home, I'll give you this pamphlet. It has the same things as the cards, so as you're using the tablet, if you find that it's not what you expect, you'll review this again and give me a call and we can discuss it again.
Okay.
All right, thank you.
So, evidence-based shared decision-making in less than 2 minutes. Doesn't always go that well, but still a very powerful way, given our time constraints, to make shared decision-making evidence-based and efficient. These 2 individuals, Deborah Cook and Maureen Mead, are intensive care physicians, and they demonstrate one of the things that's happened in evidence-based medicine is that in specific medical areas, there have been champions of evidence-based medicine. And these 2 have been major champions. Deborah in particular is probably the leading ICU person in evidence-based medicine worldwide. And she has led something that I think is really, really special. And what she has led is something that she calls the 3 Wishes Project. And what she does is she takes people who are at the end of life in the intensive care unit and addresses final wishes for those individuals. So the idea is to improve the dying process, to honor patients' dignity, to humanize the dying process for families and for ICU clinicians, to inspire a deeper sense of vocation. The wishes may be those of the patient, family, friends, or clinicians. They can be very simple. A bouquet of flowers, the patient's favorite flowers at the bedside. Or they can take something that requires quite a bit of engineering that has happened, which is merit ceremonies performed at the bedside. So, Deborah is an evidence-based clinician, clearly. She has led multi-center mixed method studies of 3 wishes. But what matters most at the end of life is usually simple. Eliciting and implementing wishes helps to personalize the dying process, brings comfort and meaning to all those attendant to that death. 3 wishes gives voice to the family and calls forth clinician compassion, been widely adopted around the world. I think it's amazing. I think it's a remarkable contribution. Final ended person I'd like to introduce you is Per Van Vliet, a Norwegian investigator, and his issue is providing guidelines optimally. He did a project with us on guidelines 15 years ago or so, and we produced nice guidelines, but he asked, are they understandable for clinicians, suitable for integration into electronic medical records? Up to date? No, they get quickly outdated. Facilitated shared decision making? No. How to make grade irresistible for clinicians, patients, and developers? How to make guidelines implementable at the point of care? How do we do it? And he decided what we need is magic. And magic stands for making grade the irresistible choice. Okay, recommendations get out of date. We now are moving toward living systematic reviews and living guidelines. And this was the first major innovative project. Per negotiated with the BMJ to do something called BMJ Rapid Recommendations, where the team scans the literature, finds something that new evidence that warrants a change in practice, and quickly gets it out on a trustworthy guideline process as a BMJ Rapid Recommendation. And a key aspect of this facilitation is something called the Magic App, which is a structured platform that allows you to put the guidelines on your smartphone. It allows you to integrate it into the electronic medical record. It allows you to adapt the guidelines, and it allows you to efficiently create decision aids. And with respect to that last, another individual I will introduce you to is Thomas Agaritzis. Thomas Agaritzis worked with us now, is working closely with the Magic team from his native Geneva, and he has worked with using the Victor Montori approach, using the Magic App, using the evidence summaries to quickly and efficiently create shared decision-making decision aids. So, we have said we need updated guidelines, trustworthy systematic reviews, living systematic reviews, living guidelines. We did very well, I think, in COVID. Reed Semenchuk and Romina Brignadello, young faculty members at McMaster, got a team of 60 methodologists. We trained a lot of methodologists, so she was able to do it. A lot of students or other young faculty members. And they were producing network meta-analyses. Network meta-analyses, another big advance in the last decade in evidence-based medicine, where you can compare multiple treatments within one meta-analysis. And they were processing up to 20 new trials a week as in the height of COVID, and incorporating it in this network meta-analysis to get the information out to the guideline developers. And I worked a lot in COVID with the World Health Organization developing their guidelines, informed by these McMaster living network meta-analyses to produce living guidelines. And one of the great things about these living guidelines is they can be on the Magic App, which we will go to very quickly. So here are the WHO recommendations on the Magic App. And here is nirmatrelvir, ritonavir, Paxlovid for people with non-severe COVID. And you can go to the recommendation, and you can have strong recommendations for those at high risk, and moderate or conditional recommendations for individuals at moderate risk. And for those at low risk, conditional recommendations against. Again, relative risks are always the same, but when you're at high risk, then you get some bang for your buck. At low risk, it is not worth it. And you can then, in the Magic app, you have the recommendation, you can look at the research evidence. And the research evidence, if you look for the research evidence, you have one of these summary of findings tables that I showed you. And then you can go to the evidence to decision, the benefits and the harms, the certainty of the evidence, that what the panel thinks about patient values and preferences. You can look at the justification. You can look at practical information, route, dosage, and duration. And you can go, if you like, to a decision aid. And with the decision aid, quickly, yes, we can view a decision aid. And you can look at admission to hospital, and admission to hospital in the high-risk patients will be about a 5% reduction in hospitalization. And for your patient who has a little bit challenged in terms of numbers, you have a visual depiction of we have 1,000 people here, and all of the black and the orange are everybody, and the orange are the people, the 5% who would be spared admission to hospital if they use Paxlovid. So, EBM in the time of COVID. Unprecedented rapid production of evidence, randomized trials using innovative platform trials methodology. We had a number of them, and within 3 years at the start of the epidemic, we had 3 interventions which we knew were beneficial in non-severe COVID, and another 3 interventions that were beneficial in COVID. We had rapid cooperation among trialists and the journals. Finally, the journals, for at least a period, were getting it, but they did. You can't delay 6 months by getting the evidence out. When it's there, you've got to get it out. The World Health collaboration that I've told you about with the MAGIC and the BMJ, where the World Health Organization recommendations, quickly done with new evidence, updated living recommendations, published at the same time on the WHO website for one audience and in the BMJ for a different audience because of this collaboration. And so the living network meta-analysis and the guidelines. In conclusion, the 3 principles of evidence-based medicine are widely acknowledged, incorporated in medical education in North America. To get your medical school or residency program accredited, you have to teach evidence-based medicine. The need for systematic summaries and guidelines, eventually still not there yet, incorporated in the electronic medical record will enhance access. That's still one frontier. Importance of values and preferences and point-of-care decision aids to help when there are conditional recommendations, the patients and the clinicians come to a shared decision-making optimum. I think, to me, COVID in the medical area, maybe not so much the public health area, but in the medical area, shows the full potential. The rapid accumulation of trustworthy evidence from randomized trials, the rapid incorporation into state-of-the-art living evidence summaries, and the rapid production of living recommendations. So, that is my summary. Whoops, what's happening here? What I'm trying to do is that. And I have just tried to give a few minutes, it's like my 10 minutes late start. So I think there is some time, I hope, for questions. Oh, it's coming now.
Yeah, so 2 questions. Thank you for that presentation. It was a really beautiful distillation of the 30 years of evidence-based medicine. So one thing I noticed in PJ's information, mortality didn't occur as a possible outcome of a GI bleed.
Right. So I was waiting when I said, any questions about it?
I didn't get my hand up fast enough. Yeah.
Oh, I didn't notice you?
No, I didn't. You'd moved on, so
Okay. Thank you for your forbearance. It turns out that the number of folks who die from GI bleeds when you anticoagulate are balanced out by the number of people who don't die for strokes when you have anticoagulants. So it's a wash. As it turns out, it's a wash in terms of mortality, which allows us to focus on the strokes and on the morbid consequences of the stroke and the disease. Excellent point.
The second question I had relates to a really insightful comment you made around indirectness of RCTs for the current growing patient population. So I was early on struck in my clinical career with a large practice of very old multimorbid polypharmacist pharmacology patients. What can evidence-based medicine do to help us navigate that space? Because it's not likely that we're going to have the number of permutations and combinations of RCTs.
We will not. We will not. And this is a frontier for evidence-based medicine. We do not produce what we think are trustworthy guidelines. Our guidelines do not handle multi-morbidity well.
Yeah.
And that leaves it up to the guy who is doing the best work in the world in terms of this, and it's a frontier, is Victor Montori.
Yeah.
You're familiar with what Victor is doing. And he talks about the burden of medical therapy on patients. And he tells us that the values and preferences are important, but the patient's overall circumstances are important. And you then have, and that's the best of shared decision making, when you understand the patient's dilemma and situation, and then you say what is important in terms of the burden of medical therapy. A big responsibility.
Let's get the funders
in
yeah.
shared decision making. But he and we're a long way from having solved the problem. We don't know how to solve it. We've got health conditions, and so I would say that's a frontier for evidence-based medicine, which Victor is one person who's leading.
Yeah, fascinating historical walkthrough. Really appreciate that. I want to point the arrow to the future and ask you about machine learning.
Okay, so what will machine learning do? Machine learning will 100%, as far as I can tell, make radiology, imaging, pathology much more efficient. It will do a great job. I think you'll still need humans involved, but it will do a great job. No question about that. Prognostic modeling, it may help you with large databases with prognostic modeling. Treatment, no. Okay. There is, when they go into the databases, they will have the same confounding problems, whatever you get it out of, the same confounding problem. So it's not going to address that problem. It's going to be, we're still going to use randomized trials to assess that. And it won't help us with guidelines. The only way it will help us is with clinicians will ask the systems, they will ask the bots, tell me what I should do with the patients. And the bots will have to hopefully give the right answer. But how will they give the right answers? They'll look to trustworthy guidelines and they'll tell the clinician what the trustworthy guidelines say. That's the way we will do that. And one of the, Donald read my hope I'm not doing something the way that I shouldn't, but it's in preparation. He sent me a draft of the paper that said when you look at AI, they make the same fallacies, right? The same cognitive, they have the same cognitive biases that the clinicians do, which no surprise because they're made to take they're programmed on the clinician anyway. So it's not going to do, it will make access to trustworthy recommendations quicker and more accessible, but it's not going to replace them. All right? Oh, sorry.
Oh, my name is Lucy.
Sorry.
So already in the programs that are used to do reviews, literature reviews, etc., there's AI tools built in that do not seem to be excellent. But considering the way research works, the people at that level who are doing those inclusion, exclusion of papers are for sure going to rely on AI tools to make their job easier, especially considering most of the students. So when we're looking at systematic reviews where the human oversight is already, even without AI, we sort of accept with students, you need to have multiple students looking for conflicts and things like that. Like, what does that mean for the quality of systematic reviews in the first place if we don't have guidelines on how to ethically and effectively adopt these AI tools, which is also going to, lab directors want to save money. They don't want to pay for the best RAs. They just want to get as many volunteers in as possible.
Okay, my students aren't using it, okay? We're still doing the systematic reviews in the way we all do, okay? I expect my students to figure out if there's something that really works. If there was a Google for making systematic reviews efficient, everybody would be adopted. They aren't there. And in the interval, and by the way, I'm particularly fortunate, yes, people have to pay research assistants, but you pay, you also have many students, I think, in many places, certainly where I work, who are ready to do this for the learning and the publications. And they do learn a lot, obviously, through doing it. So I suspect there will be AI tools eventually. I can't see why not. With everything it can do, they should be able to get to the point where they make the identification of the studies and the data extraction and possibly the risk compliance assessment. They should be able to get there. I expect they will. They haven't yet, and until they do, when they do, great, no problem. Until they do, we will still continue to do it the way we've always been doing it.
I think just my concern is in the interim. I've seen these AI tools. They're not good. And that's one thing if you have a supervisor like you who really is, choosing your volunteers because of their passion for this, supervising people in a meaningful way so that they're learning. However, there's so many labs out there where that's not the standard. And I'm wondering, how do we, in this weird window we've got, where the tools aren't good and you still got these kind of spaces publishing that haven't necessarily done the work, to ensure that the systematic reviews that are coming out are actually of good quality?
Well, was your supposition that these not so good places were still doing good work without the AI? Is that your supposition or not?
You know what? That's a very good point.
If I would contend, if they were doing good work, they know enough not to use the AI until it's ready to do. And if they weren't doing good work, they weren't doing good work, and the problem was there before, and it's not the AI, it's the problem they weren't doing.
Good point. Thank you.
One last question, then we'll have our coffee, please. Cindy?
Thank you. Good morning. I'm Cindy Ziegler. I'm not in a medical position. I'm a sociologist in education. And looking at the future of evidence-based medicine, I'm just wondering if you have taken into consideration in the future the change of our patient population, the diversity of the patient population, how we're they react and how it is. Looking at the video that you showed, where there was physician and the patient having that communication and conversation with patients who don't speak English or the language and who have difficulty reading or understanding. How do you see the kind of support for these patients in the future in part of diversity and culture, education, communication?
Well, we are still often a shared decision making. It's still a frontier, and you raised issues. It's challenging even in the highly educated English language speaking patient. It has challenges. It has obviously in the situations you were talking about much greater challenges. And I think enormous work still needs to be done at the frontier of evidence-based medicine to have this for all time be straight. And so it's not only making it happen, but it's making it happen efficiently. And we need lots and lots more work to figure out how to do that.
Welcome back, everyone. My name is Upshur, and it's my great honor and pleasure to be the chair of the panel discussion. Just wait for everybody to get settled, and if we can call all of the panelists to the front. Allan, we're calling to the front. He's deep in the best part of these are deep and engaged discussions. So after a very distinguished lecture from Dr. Guyatt, we have a distinguished panel to provide comments and focus on the future of EVN. So I'm going to introduce the panelists in the order in which they're going to speak. Our first panelist will be Professor David Naylor, who is well known to the University of Toronto community. If I read out his entire bio, we'd still be here tomorrow. But suffice to say, he was actually the inaugural director of the Clinical Epidemiology Unit and Research Program at Sunnybrook Health Sciences Center. That's it. That's enough. Dean Emeritus, President Emeritus, member of Medical Hall of Fame, and most important to today, Friesen Laureate in 2018. Our second speaker is Lapointe-Shaw, and she's an assistant professor in clinician science track in the Department of Medicine at the University of Toronto, and a staff general internal medicine physician at the University Health Network. You're going to see a kind of strong internal medicine bent towards this panel. In 2019, she defended her doctoral thesis relating to the transition of patients from hospital to home. She won a CIHR Fellowship Award and the CIHR Institute for Health Services and Policy Research Rising Star Award, and has been supported throughout her research program by the Elliott Phillipson Clinician Scientist Training Program at the University of Toronto. And last but not least, we have Professor Allan Detsky, who's a professor in the Institute of Health Policy Management Evaluation, HPE, and the Department of Medicine at the University of Toronto, staff physician at Mount Sinai Hospital and University Health Network. He was the physician-in-chief at Mount Sinai for some years and was also the University Division Director for General Internal Medicine. He's won a Career Achievement Award from the Society for Medical Decision Making, and germane to today, he was a David Sackett Award from the Canadian Society of Internal Medicine. He was appointed to the Order of Canada in 2018. So a very accomplished panel to task us to look towards the future of evidence-based medicine. I'm going to hand it over to David then to start off.
Thank you very much, Ross. Ross was our family doctor. You recall he was talking about multimorbidity and people were falling apart. I was very pleased to be one of the early subjects in that.
That's right. I wasn't going to point any fingers, David.
I wanted to, since the other guy did not get a full bio, to say a little about our honor. We extend warmest congratulations to Gordon on the latest method of the ongoing Friesen Prizes. His contributions to health professional education and research and health policy making are extraordinary. I have to acknowledge that Gordon, unlike some of us, did not become mired in the administration. As long as I've known him since the time of the Boer War, he's been a long-standing local champion of universal health care. He has focused, as you heard about, on the generation, interpretation, and application of insights and evidence for clinical care and the healthcare goals of the state for. There is, however, one special note that I want to make on this prodigious achievement. Gordon, you may not know, was a candidate in 4 federal elections in 2000, 2004, 2006, and 2008. And I would like to thank the voters of the Hamilton region who recognize that Dr. Guyatt should keep doing what he has done so far. Leadership takes many forms, and I want to just share with some of you who may not have been around in those early days of EDM, that the crystallization of the ideas that Gordon so impressively undertook was not met with universal approbation. The critics foresaw here a cookbook medicine and the death of the art of medicine. There's worry about diminution of the value of basic and translational science, a rejection of time-honored interests from human pathophysiology. All in all, this was heavy sledding to move it forward. But if sending in after criticism can also be an act of purification. I think Gordon, that backlash was actually helpful in some respects, as refining things like the emphasis on practice patients, and would certainly stand as well. That said, I want to also acknowledge some realities. The missionaries of EBM included inevitably some narcissists and some blinkered zealots. And so we had this sort of Cro-Magnon medicus looking down from open lights at the ignorant Neanderthals on the clinical coalface, and it didn't play well. Gordon Guyatt never went there. He was a role model of reason, restraint, and sensible persuasion, as you saw today. He was a superb educator, not only with scores of trainees, running a residency program, but of the profession at large. And I admired that greatly. Another point about Gordon that may not be recognized by the audience is that he has remained a very active researcher. Some of the exponents of EBM, in my view, became armchair critics of the status quo, pontificating on methodology and endlessly dissecting the deficiencies in the research methods and practices of others. In contrast, Gordon was not only a thought leader on myriad fronts, the author of important educational work, and the embodiment of effective knowledge translation, as you've seen, but he worked nonstop on randomized trials, collaborating with countless individuals worldwide, and publishing heavily, adding to the store of new knowledge based on hard work and elbow grease. So in that sense, an extraordinary role model, a visionary who never hesitated to pick up a shovel and help others dig for new insights and better evidence for more effective care. I have a minor grumble or two about the presentation and some questions and head scratching about where EBM is going, but I want to come back to that only later if there's time. For now, I just want to say, Gordon, how happy I am to see you honored this way, and I'm very glad that the Friesen Prize has come your way.
Thanks very much for the opportunity to sit among these illustrious panelists and in honor of somebody who's really shaped, I think, all of our careers. So I will just say, as the junior member here, I think EBM continues to be the highlight for me in many ways of the internal medicine program. So I trained at University of Toronto, and we regularly have journal clubs. And in fact, when I became chief resident, I sought out to sort of revamp these journal club rounds. And I have vivid memories of sitting at family camp, which is like, outdoor cabin, reading the user's guides to the medical literature in the sunshine and actually really enjoying it, like this exploration of methods. And it subsequently led me into pursuing a PhD as well. And so, and that's just the direct ways. There's all the countless indirect ways in terms of the treatments that we use and the decisions we made on the ward that I think touched so many of us. So thank you for that. The practice is alive and well. I did want to comment about, and I'm sure, probably Allan, you may have comments about this as well, on the sort of shared decision-making side of things. Going through medical training, of course, probably at the time I was going through, a lot of these tools were coming out, these visual aids, and we're sort of introduced to, this is how you would have a conversation with patients about making a key decision in terms of their treatments. And moving into practice, and I think I'm sort of curious because you practice the same type of medicine I do, which is this unscheduled, acute care of people with multiple conditions in a very time-pressured environment. Unfortunately, I don't see these aids being used, so I'm coming out and saying it. I don't use them, and I was reflecting on why is that, and what are these aids really useful for? And certainly the example you give of an endocrinologist, where you're repeatedly having discussions about diabetes medications, this idea that you're sort of seeing the same conditions over and over, and so there's a lot of the same decisions coming at you over and over. It seems ideal. You could say also maybe for surgeons, having a discussion about risks and benefits of a procedure someone's going to undergo. But it all kind of breaks down in that acute care environment where people have multiple conditions. Often they don't speak English. The environment is not great. And so even if you do sort of muster, okay, because I think the times I probably did this type of discussion anyways, not with visual aids, related to warfarin. We did it a lot from warfarin. It was, okay, this can reduce your risk of stroke, but, the risk of bleeding, et cetera. It's funny how patients don't enjoy more uncertainty and questions, particularly when they're, acutely unwell. So a lot of times I'd get answers like, well, you're the doctor. Why are you asking me that kind of thing? So, I wonder about that tension in terms of patients, and maybe it again relates to the type of setting. Like outpatient, they tend to be less stressed probably than an inpatient setting. But the shared decision-making on the ground in those acute environments. And I thought it was really fascinating actually to think about, the distribution of patient opinions in terms of tolerance for bleeding. But again, it made me think, in an acute setting where you're stressed, like how many of those patients would say, I would actually prefer to just be told what the average patient choice is in this situation? Like if you could come to them and say, well, typically this is what patients have said on average in terms of these risks and benefits, they might be like, oh, phew, like, it's just sort of information overload in that moment. And so I wondered if any studies had ever been done actually in that area of sort of asking patients, if presented, like what would you actually prefer in a moment of stress? Would you like us to sort of present you with what the average patient said when we studied patients' opinions about this, they were not stressed, versus sort of asking you to come up with weighing the pros and cons? So those are my initial thoughts about that. I don't know. Pass it over.
I'm in the little boy chair. Well, first of all, thank you, Gord, for coming here and giving this talk, and thanks, Peter and Ross, for inviting us to be on this panel. I'm sorry we don't have a larger audience, but I guess in this era, people don't show up for these kinds of events anymore, which is kind of sad. So, first of all, that was an extremely elegant talk, Gord, and I'm not surprised that you would give an elegant talk on evidence-based medicine. It's been your life. I, too, lived through the era. I was an intern in 1978 and decidedly remember giving lidocaine to every patient with a suspected acute myocardial infarction because it was going to stop them from dying from ventricular tachycardia and VFib, and it turned out when we saw the evidence that it actually did the opposite. So I remember those kinds of mistakes vividly. That's the example I use about the mistake of functioning without evidence. But I completely agree with everything you say about how far we've come in the last 45, 50 years in terms of generating evidence that will help patients, I don't call them patients anymore, people, and the clinicians who care for them to make decisions. But here's the big buts. And so none of this diminishes the contributions that you're talking about. Those are overwhelmingly positive. But these are my concerns. The first concern is, it relates to what Lauren was saying. I was a hospitalist. I have done over 200 months of attending on inpatient service in my career. I no longer take care of patients. For the last year, I stopped. I would say that maybe 5 to maybe 15% of the decisions that I made with the people that I cared for could be solidly based on evidence-based medicine, and the other 85% was an extrapolation. And the reasons there were extrapolations wasn't because there wasn't individual evidence about thrombolytics or about an infliximab or about anticoagulation. It was because the patients never really fit the evidence, the pure evidence itself. It wasn't generalizable. They didn't just have one thing wrong with them. They rarely had one thing wrong with them. They rarely were of the same age. They rarely had no other medications that it could conflict with. And when we see a lot of the trials now, like Dave Cherney gave an elegant talk yesterday on the various therapies used to prevent progression of chronic kidney disease, and they were layering on one drug that gave 20% benefit to another drug that gave 20% benefit to another drug that gave 20% benefit, and there was no trial of 5 drugs versus no drugs, 5 drugs versus 3 drugs, or worse, there was no trials of 5 drugs in people who also had heart failure and arthritis and dementia. And so our patients are so much more complicated than the guidelines can ever give us hope to treat in a pure sense, that your mind I'm commiserating with Lauren's point of view. You're standing there in the middle of 6 admissions that day. You've got 6 terribly, tragically ill people in front of you, and you're trying to make decisions with them and their families, and they don't even understand what you're saying, and it's an acute time. It just doesn't translate, in my view. My second major concern is the extent to which, is this still on? Yeah, the extent to which pharmaceutical companies have taken over this industry of evidence-based medicine. The vast majority of the trials are going to be done by pharmaceutical companies for the right reasons, because there's not money to do a trial on everything. And it's not, my friend Chris Booth, who is at Queen's, has taught me how in oncology, trials can be easily corrupted into showing a benefit using endpoints like disease-free survival.
False alarm, sorry.
Using disease-free survival. Is that me?
No, I was trying to turn this microphone.
Oh, okay. I thought it was my echo. It didn't sound like me. I forgot what I was saying. Oh yeah, can be easily corrupted by using endpoints that don't matter or designing the control arm to be something that isn't realistic anyway to maximize the possibility of evidence. Now that's good for showing proof of concept because you do want to give it a new drug its best chance at showing effectiveness, but it's not good for translating into patients. And we treat so many patients at the end of their lives with cancer with drugs that are not making them better off for the reasons that you pointed out. It's not what Deb Cook has pointed out. It's not really what they want at the end of life. So those are my two biggest concerns: is lack of generalizability and corruption by individuals, entities with conflicts of interest. And it's not limited to drug companies. It's limited to other vested interests. But that's not really what I want to say. What I really want to say is to acknowledge the history of how the Department of Clinical Epidemiology and Biostatistics at McMaster spawned the clinical epidemiology efforts here at the University of Toronto. And if you'll bear with me, I'm just going to tell a very brief story. I came back to Toronto in 1980. I was hired by Gene Veda to be a health economist in what was then called the Department of Health Administration, which is now IHPME. I was also recruited to the Department of Medicine. In medicine, they said, well, economics is cool, but ClinEpi is the future, and we need people to spearhead this. And I said, my PhD's in economics, not in epidemiology. I don't know anything about epidemiology. Where am I going to learn about that? So somebody suggested that maybe I should touch base with the people at McMaster. And that was primarily Dave, Mike Gent, Brian, Wayne Taylor, Peter Tugwell. And they said, why don't you come here one day a week and you can go to our work in progress rounds, you can come to our grand clinical epidemiology rounds, and you can meet with people, and we'll mentor you in learning about clinical epidemiology. And that was how I learned about clinical epidemiology. I also learned how to be independent, and this is a good story. 3 years in, I was presenting one of the work in progress rounds, and it was on a very elegant topic on using cost effectiveness analysis to analyze decisions around sample size choices, the costs and benefits of making it larger or smaller. And I had a list of questions, and there were all these really smart people in the room who knew a lot about everything. And I asked a question, and they would answer, and go, no, that's not right. And then I'd ask another question, and they would answer, and that's not right. And I asked a third question, that's not right. And then the light bulb went on in my head, and I said, I know more about this topic than anybody else in this room. I'm independent now. And I wasn't completely independent, but learning how to go out on your own was a key thing that the group there taught me. And finally, they were very lovely. All of our students, Robin McLeod, Dave Urbach, Howie Abrams, Alison McGeer, they all accepted them into the ClinEpi program as a side door to support us in Toronto. And finally, they said, we can't do this anymore. You have too many good students. So it spurred Claire Bombardier, me and Sandy Logan and Tony Miller to create the ClinEpi program here that's cited within Staney's division, Staney's faculty now. And that happened, again, because they kicked us out of the nest and said, it's time to go out, you're ready, you can do this on your own. So if it had not been for the Department of Clinical Epidemiology and Biostatistics and all of those wonderful people, including you, we would not have what we have here at the University of Toronto. And I want to pay tribute to that.
So why don't we have another sort of round of questions or comments, and then let Gord respond to them. So why don't we sharpen our focus a little bit towards the future of evidence-based medicine? Maybe look, so you nicely recognize some frontiers where more work needs to be done. There's certainly, we alluded to one of them around machine learning, but what about the increasing focus on precision medicine and this sort of convergence of machine learning, artificial intelligence, and the advent of very potent genetic technologies? Is this a complement to, a challenge to evidence-based medicine? And whatever else our panel wants to sort of opine on would be great. Also, how we think about structural issues like social determinants. So there's sort of two, I think, bigger challenges out there. And David, it looks like you're ready.
Yeah, I'd like to start on the precision medicine front. Just a confession, I'm an unabashed clinical epidemiologist, even though we were told that was a contradiction in terms. You'll remember, Allan, in a paper that we had to publish to rebut the big E epi people. But I guess I am a mild heretic in the church of EBM. Not an apostate or an infidel, I hasten to add, but someone who has some reservations. And my reservations are based around the fact that EBM is in many ways epidemiology-based medicine. And the notion that applicability is defined by preferences in the context of epidemiological evidence is appealing. I actually think I said that in 1995, 7 years before Brian Haynes, but never mind. That's an appealing concept, but there's a real problem, and that is that increasingly, because of the convergence of data science and machine learning and molecular biology, we are seeing more and more delineation of decisions at very small subgroups, impossible to chase clinical trials in all of them. And we are also seeing individuation of treatments, particularly in cancer, but spreading to other areas, based on that subgroup delineation. So I guess my question for Gordon is this. We've got EBM, we had molecular medicine, and we had precision medicine and personalized medicine of all types. We're clearly into a realm where there is what's often positioned as a competing paradigm based on translational science. I guess my view of this is that the analogy here that doesn't work is physics. So Newtonian physics governs what we do. We're not into quantum mechanics and Einsteinian relativity, even though that's a refinement of the paradigm. In the case of EBM and the rise of precision in molecular medicine, I don't think that holds. We don't live anymore in the equivalent of Newtonian physics or EBM only. We live in a realm where all of those techniques are now starting to affect care. They're starting to affect applicability and individuation. So give us a sketch, if you can, of how it is that these two paradigms converge, because I think they have to converge, and where you see the future going, given the rise of applicability and individuation based on all these subtle inter-individual characterizations driven by molecular bio and AI, because that's coming and it's already with us in many fields.
Do you want to answer that question now, Gord, or take a few more challenges?
Sure.
Okay, go ahead.
If I don't answer them right away, I'll have forgotten everything by the time it gets to me. As far as I can tell, and you'll probably correct me, but as far as I can tell, everything you described can be perfectly compatible with EBM subgroup analysis. Okay, so what you're talking about is subgroup analysis. You're talking about a particular group who responds differently than other groups. And in other situations, the usual situations, we need randomized trials that are big, that have enough patients that you can look at subgroups. But if there are enormous effects in a particular, if you take somebody with a particular gene structure and everybody responds to treatment, and you take somebody without it and nobody responds to treatment, okay, those are giant effects, and EBM covers situations of giant effects. I said a number of them. It's as far as I can tell, it's simply subgroup analysis with EBM principles that apply very readily.
So we all grew up being chastened about slicing and dicing and subgroup analyses that were done post hoc. So can you elaborate a little bit on how this marriage is supposed to work? Is it all going to be pre-specified? Is it all going to be determined in advance by biological characterization? What if the biological characterization in the initial studies show everyone responds, in which case randomization isn't feasible or ethical, which is happening in cancer right now. So is this all completely assimilable, or is there not a need to think hard about where these fit together rather than saying just another form of subgroup analysis? I'm not sure I buy that.
Well, so like with anything with new areas, and we find it all the time, you have to refine the principles for the particular area. And as I have, one example I use is if somebody comes up with something that is objection and an amputee grows a new limb, you don't need a randomized trial. So if these effects are big enough and consistent enough, then you have your answer. Then you have to say, okay, when is big enough and consistent enough? Okay, so we have standards in the randomized trial situation. Somebody who's working in the area needs to, which I am not, somebody will need to say, okay, when are we far enough along that the evidence is compelling enough that we believe it, and you're in a new paradigmatic situation, but that's what you have to develop. Paul Glasziou and others have written papers that say if you look at the FDA, they are making their decisions in a lot of these situations where the effects aren't terribly big. I don't know about it, but but I would again say you're applying the same principles. The principles have to do with a convincing demonstration of subgroup effects and follow EBM principles of large or very large effects, which if you see those, you are ready to say you've got compelling evidence. So it needs to be refined for this, and ideally thoughtful people working in it would start to say, okay, let's look at examples where the FDA said yes, and maybe it wasn't such, maybe it was premature, and others where it seems to be. What are the exact standards that apply to that particular thing? But you are, as far as I can see, you're applying exactly the same principles and refining them for the particular situation.
Good. Allan or Lauren, do you have a challenge you want to ask? I think, Allan, you asked two particular questions.
Mine is a little bit of a pivot, so if yours is...
Mine's a big pivot.
Oh, big.
Okay, so to Lauren, two big, a small pivot and a big pivot, and then...
So I want to pivot a bit to complex health interventions, because I think, the whole paradigm, the RCT being the sort of the pinnacle of creating evidence, applies the best, I think, to drugs, because, internal validity is prioritized, and then proof you have an out-of-the-box solution in the form of a pill, easy to implement. I mean, sure, there's issues with adherence maybe, but mostly, very scalable. For complex health interventions, we know, context matters so much, engaging local stakeholders, how you roll things out, how you actually pivot, modify as you go. And so I wonder how much this framework, this sort of potentially some degree of rigid adherence to the standard of RCTs, how that could be best adapted to complex health interventions, acknowledging, I think we've had a lot of great developments in that direction in the form of cluster RCTs and step wedge designs and pragmatic RCTs that can all be used in that direction as well. But even with all of those models, there's this idea that, the external validity is often, and i.e. this sort of scalability and how you can implement things in different settings, often ends up being as or maybe even more important than sort of that any sort of element that you could distill down that would be the same, no matter what the context is. So, how can we move forward in terms of having feasible studies that meet our previous standards of, what constitutes robust evidence, when we know that, this type of complex health intervention really needs to be tested, developed, refined in vivo in the place where it's rolled out. And then when it gets scaled, often needs to be re-rolled out and readapted and modified. And so how can we reconcile these things?
All right, Gordon, you want to answer that?
So one of the great domains is indirect evidence, okay? And so there are a number of things that you suggested, and maybe I haven't got it right. But you're suggesting one situation where perhaps you have a randomized trial of a respiratory rehabilitation program, and it seems to work. And now you're saying, okay, now we take it to another situation where the patient population differs, or you don't have some components of the thing, and so on and so forth. Okay. And you say, okay, we have indirect evidence from this other setting. Okay. Now, you do one of two things. You either go out and test again, which may or may not be feasible or appropriate, or you acknowledge the indirectness and say, we're at a lower quality of evidence. And then you make decisions. You say, well, probably works okay in this population as well. Oh, probably if we leave out this component, it'll probably work okay. Maybe and maybe not. And you're into some analogy to physiologic rationale of, okay, what's our understanding of the biology of this population difference or of this aspect of the intervention difference? And you got to make choices. And the point is to we're not going to have the resources to do infinite randomized trials, and it may not even if we did, it may not be feasible in a particular setting with particular circumstances, but you've got to make choices. But you apply evidence-based medicine principles to acknowledge the indirectness, look at the extent of the indirectness, and then say, okay, probably it works and we're ready to invest resources, or man, we are really not so sure and we probably should invest our resources elsewhere.
Great. Over to Allan for the major, and then we'll have the panelists have
Your flashlight is on your
last
phone.
comments, and then
You're holding your, sorry, I don't know your name. Sitting next to Abby, your flashlight is on and it's flashing in my,
yeah.
yeah, it's going to give me a migraine. That's how I get migraines, from flashing lights. Sorry, people don't, when you have your flashlight on, sometimes you don't realize it. I'm going to pivot to something completely different. And I want to really ask you about the Victor Montori stuff about multimorbidity, but that's an intellectual thing, but that's not going to satisfy me today. So I'm going to ask you a different question. My career started in 1980 as a scientist and doing research, generating evidence. Prognostic studies, like a big area was cardiac risk in surgical patients, nutritional status risk in surgical patients. Then I went on to talk about conflicts of interest and economics. My career really started as research. But in 2007, I got hired by JAMA to be something called a contributing writer, which meant writing op-ed pieces and stories. And the rules were, Kathy D'Angelo set up the rules. She said, no new evidence, so you don't have to generate new data. I said, oh, well, that's easy. You have to have a point of view. I said, oh, that's easy. And she said, and it doesn't have to be balanced. I said, well, knock me out. Like, I can do this. And so I started to write op-ed pieces, and then I started to write stories. I got into the piece of my mind part of it, and I've written stories in other journals too. And you know what? As my career moved on and on and on and on, I became way less interested in the research and way more turned on by the stories. The things that I have learned from taking care of individual people that have affected me for my entire career. Now, I can't say that evidence-based medicine isn't a stronger influence. Like, choosing what we do is been based on evidence-based medicine. But as I said, it's only been somewhere between around 10% of my decisions that were solely based on evidence-based medicine. But learning how to treat people from stories is now way more engaging to me. So when I look at the new issue of the journal, the New England Journal or the JAMA, I go straight to the stories, to the perspectives of their stories and the piece of my minds. And those are the only things that I read. I'll glance over the trials, but it's the latest drug in multiple myeloma. I was like, not turned on by that. Or the latest thing to add on patients with type 2 diabetes. I'm not turned on by that. But I am turned on by the stories that people tell. So I'd be interested to know if you read the stories and if you think the stories have influence on what you do.
No. But I absolutely take your point in that perhaps my own favorite talk is telling the story, a series of stories. I practice hospital-based general internist, and a lot of my patients are cognitively impaired. I believe I do 10 weeks a year. I'm not a hot shot latest of the so on and so forth, but I think I do a better job than my colleagues at taking care of my elderly demented patients. And so for one thing is I'm very frequently coming in and seeing somebody with a very poor quality of life where more is being done to that person than is appropriate. Happens all the time. And I've developed a strategy where I say to my first question to the caregiver is, tell me about the quality of life of your loved one. And sometimes they surprise me. Oh, the guy's dancing with the nurses. He loves okay, all right, end of conversation. But very often it's terrible. And then taking them through, okay, what do we want done? And in the end, we've withdrawn everything. We've stopped vital signs. We have moved just to comfort care. And I could tell lots of stories like that. My very best story is of I was coming on to clinical service, and I was coming on to the new ward, and there was a woman sitting there talking to somebody else, and she's saying, oh, nobody comes to see me, my family doesn't come to see me, the doctors don't come to see me, they're not paying any attention to me, and it's awful. And the person said, I've seen you around, you're laughing and cheerful all the time. And the person replied, what's wrong with laughing? What's wrong with being cheerful? And I thought, I wonder if this is going to be my patient, and it was. As it turns out, she had, the range of dementia is extremely variable. She had the short-term memory stuff bad, but everything else was intact. So I go to her and I say, and every day when I was told by the social workers and the rest of the multidisciplinary team, we decided this woman can't cope. And every day I go to see her, she says, I can dress myself, I can feed myself, I can do all these, I can do all my activities of daily living. Why are you telling me that I can't take care of myself? And she tells me this day after day, and after a while I say, why are we telling her this? So I go to the social workers and I say, hey, has a proper assessment been made? No, the proper assessment hadn't been made. So I say, okay, you should make the proper assessment. Well, then it so happens, and another of the things I do that I don't think very few other people do, it's just because I do 2 weeks at a time. But I couldn't do this as an outpatient. I give my phone number to every patient. Every patient found that we have boards in the room, which is nice. Every time I go in the room, first thing I do is give my phone number out. And that has proved very useful. Anyway, Mabel was this woman's name. So I'm in the room with Mabel, and she gets a phone call, and it's her daughter. And I say, oh, can I talk to your daughter? And the daughter says, I start talking about it. She says, oh, I came to, she's out in Vancouver. I would love to have Mabel living with me. But I came and they told me you can't have Mabel living with you. You'll go out there and you'll have 3 months and you'll have nobody to take care of her and you work and it's just not going to work. So I say, what's your financial situation? could you hire somebody for those 3 months to do it? Well, as it turns out, their financial situation is just fine and they could hire some. Oh, nobody suggested that to me. Anyway, the upshot of this was before I finished, things moved quickly, before I finished service, she said, okay, my brother's going to come out, we're going to get Mabel, we're going to come and we're going to, and Mabel's now going to live with us. And we're all very happy, all very happy with this situation. And then I get, every time I tell a story, I get emotional, but at the end, Mabel says, you've really done something special for me. And I say, oh, you know, it's my job. And Mabel says, nah, you've done something really special for me. And if I think of all the things I've done, there is unequivocal evidence in my mind that I really did change this person's life. So, so maybe I should start reading all the stories that you're reading to learn.
Yeah.
Okay. Send me. I would be delighted. But I told that one that I think I absolutely believe that stories are important, and that sometimes I framed this talk that here is a certain type of evidence that in certain situations we can really do something special for people.
Yeah, so we're close to time. If any of the panelists have a last comment they'd like to make before we hand over to Peter to close. I think we saw a softening and an opening between the fusion of narrative-based medicine and evidence-based medicine. And it's kind of a key. Everybody likes Cochrane's book, but one of his most compelling stories, one of the best things that he said he ever did, was to provide care in the prison camp to somebody who died of tuberculosis. He was the physician for the camp. He had no drugs whatsoever. And in his mind, that was one of the most significant things that he had ever done. So I think we're seeing the real importance of clinicians' lived experience and patient narratives as a complement or more fuller, robust notion of evidence. So thank you to the panelists, and I'm going to turn it over to Peter to close our proceedings. Yeah, do we have any last questions? Oh, we do, okay.
I have a question. Dr. Guyatt, the early part of your presentation impressed me enormously because I think you reinforced the point that textbooks are obsolete.
Physical one.
Pardon me?
Physical textbooks.
Depending on the definition of textbook, is up to date a textbook? Anyway, if it is a textbook, then textbooks are not obsolete. If it isn't a textbook, then textbooks are obsolete.
The wonderful pamphlets that come up monthly, as opposed to the heavy books that we're understanding as Harrison's textbook and the variety of textbooks dedicated to subspecialties. And the fact is that there is a 10-year hiatus between the observation and confirmation and reaffirmation of science to its application at the bedside. And I wonder if that's a continuing problem and resulting in textbooks just being...
The textbooks you're talking about are ancient history. They're dead. They're dinosaurs, okay? And even the guidelines that come out by august societies, where they put a guideline out and they wait for 3 years to put out their next guideline, the sooner that becomes history, the better. Okay, now, I am gigantically conflicted because I've been working with UpToDate for about 15 years. I'm still working very regularly with UpToDate, and my job with UpToDate is to make them more evidence-based. And their claim, which they might not always do, is new practice-changing evidence comes out, UpToDate changes within 2 weeks. Well, sometimes not, but that's certainly the goal. And I, of course, have to believe they're doing a pretty good job of it. And there is no question about its unbelievable popularity. I can go anywhere in the world. If I'm in an academic audience, I say, which of the clinicians using UpToDate? 2/3 of the people put up their hand. And so I'm obviously very conflicted, but the model of, and if the specialty societies can do it, great, they should be doing it. UpToDate's got they've got a system where they can change quickly and hopefully most of the time be evidence-based in the changes they make. The specialty societies need to develop it. because we need living systematic reviews and we need living guidelines. There's no doubt about it, and that's where clinicians have got to go. And anything other than that, the textbooks are obsolete, and the periodic, every 3 years we come out with something, that should be obsolete too.
One last question.
Yeah, thank you. My name is Stephen. I'm a PhD student in medicine science at the University of Toronto here, and also a part-time student in the postgraduate certificate in teaching evidence-based healthcare at the University of Oxford. My quick question is, how are we doing in terms of developing, we're talking about the future, right? So how are we doing in terms of developing leaders for evidence-based practice within the Canadian context here? I mean, I'm looking at us here. Majority of you are our senior colleagues, but where are the much younger? You know, the students, where are they? How are we doing in terms of that? Because it does appear, I don't know, since the momentum seems to, maybe I'm not seeing, I was happy for this program really, and I couldn't wait to attend. But I look probably to other countries and I see there's a lot of momentum ongoing, but seem to be not seeing much of that here. So if you can comment on that.
I think the best person to do that is the person who's held the very senior perspectives of looking over the whole system, David.
So it's a fantastic question. I'm very concerned about the receptor capacity. We have a fair bit of money in the system. It's fairly short. For the first time, I'd generally say it's enough. No, I'd say we're short, pretty clearly. The pandemic has laid bare as a sort of stress test the faults in the architecture of the system. And if you have a straightened system like ours, where all the health professionals feel under siege, where many were sort of burnt out in the pandemic, I think it's much harder to build in decision aids, take the time to talk to patients in conditions of uncertainty. I think it's much harder for people who want to practice evidence-based medicine to find the time to stay up to date, despite the excellent resources available. So I think what Canada has done is to give the world evidence-based medicines, thanks to Gordon and his colleagues, and many others internationally before and after, who sort of laid foundations in fairness. But we have created a healthcare system that, despite all the educational uptake, the healthcare system does not have the capacity to really capitalize fully on what we've got, and it's disappointing.
It's a sad note. I would say I think that, there is hope, and there are many young people who are taking up the charge of, there's been a bit of a return of Clonepi, at least in our GIM group. We have many colleagues of my vintage now, and sort of return and expansion of methods and network meta-analysis, Bayesian methods, lots of mixed methods, lots of implementation science, and I think there is energy around this. But it's always the issue of critical shortage of resources, CIHR budget not keeping up with inflation, that makes it difficult. But I think nonetheless, there are willing partners if we can find them.
So optimism is always better than pessimism, but hope is not a strategy, any more than despair is a strategy. So, I think there really is a need for academic medicine to get on the barricades about the changes in the system, the degradation of the system. We have ample evidence of the stresses on it, and we need a constructive rebellion in the caring professions to put pressure on decision makers to clean up the way we do things and make it more amenable, because there's nothing worse than creating tremendous talent, underfunding it in research, and then creating conditions that don't allow all those people to innovate and be creative. And the one thing we've learned from past reviews is there's tremendous creativity on the coalface, but scaling it, evaluating it, of course, improving it, but scaling it, done very poorly in the current system. So I'm very concerned, more than I've ever been in 30 years of talking to governments and dealing with this stuff, that we have a kind of hiatus with all this talent exemplified by Lauren and others, and we don't have the receptor capacity. So I really would urge people to raise their voices and press for change in the system.
Okay, so, that was a great lecture and roundtable session with the discussion and questions. Thanks to Gordon, Steiny, Ross, Allan, Lauren, and David, as well as the audience for their contributions and participation. Personally, I've learned a lot about a clearly developing field of evidence-based medicine, even after 30 years since its inception, and today especially around the advent of AI and its impacts in this area. If the Friends of CIHR wishes to thank our lead sponsors for this event, University of Toronto Vice President of Research, the University of Toronto Temerty Faculty of Medicine, the Hospital for Sick Children, the McLaughlin Center, University Health Network, and finally the Dalalana School of Public Health. The Friesen Prize and related events today are organized by our colleagues at the Friends of CIHR, as I've mentioned, and I wish to thank all of our executive and board directors. We have two here, our Vice President Andrea Baumann and Reinhard Reithmeier, our treasurer. We're very much looking forward to our planned visits to other universities across Canada. I'm sure we'll be hearing different, but probably also similar comments, so in the coming months. So please thank you for all being here, and have a great rest of your day. Thank you.